All right. Welcome back. Good afternoon. We started with good morning. Now it's good afternoon. I guess most people are yet joined us. Earlier on, we've clocked in the 1,100 mark rather, and now we are just about 20. And my first slides for this afternoon, I lays the foundation for the conversation going forward. Let's see. Oh. So we'll start, and hopefully because it's recorded as well, so maybe all those that are yet to join us will at some point join us. Yeah, we'll just start. So let me admit a couple of people joining. So yeah, research for clinical impact. In the morning, we laid the foundation for healthy aging, and specifically we talked about falls and the impact it has on an individual, and the role, how we can approach it systematically, and our role as physio. Now we will, from now till the end of the day, we'll be looking at research for clinical impact. We'll broadly start looking at research, and specifically we'll look at the specifics, because I will not be each component. I can take a component and talk for the whole day, but we'll try to paint a picture as well, like we did in the morning, of research that is relevant. And we try to link it to our clinical practice, to your clinical practice. And you can modify it. The whole idea is you should be able to modify whatever we discussed now to your clinics, whether you are in the falls or not, whether you are MSK or not, whether you are in neuro or not, cardio or not, pediatrics or not. This is important or applicable to your setting. So by my right hand side, there is an image which I shared in the WhatsApp group as well as in the chat function. So the image has sort of a cross, up and down arrow crossing each other. And I will start with the image, with the one on my left hand side, the primary. So we'll start by talking about the research itself, and then we move on to talk about the examples. I use the examples of falls simply because we've already talked about falls in the morning. But you can think of your setting, and I'll be asking people to think on their settings on how they can apply it. So broadly speaking, we all know that in research, we can have primary research and we can have secondary research. That is the horizontal line. Okay, we can have primary research and we can have secondary research. These are the broad classification. And primary research, by definition, it's about, think of us as the primary source. So we collecting the data from the participants. We directly collecting the data from the participants. And from my experience, most of the undergraduates is what we've done, mostly primary research, where we recruit, we collect data, we analyze, and then we report. But another form of research is secondary research, where we don't collect the data directly from the participant or from the source. It doesn't have to be participant, from whatever source it is. We relied on the information already available or done by the already from the primary research that has been conducted to do our own secondary research or secondary analysis or whatever we call it. So secondary research relies on the information that has been done on the primary research. And there are different types of primary research, as well as there are different types of secondary research, which I think if I open the conversation here, a lot of people will share their experience and expertise on the primary researches they've conducted or they are conducting, as well as the secondary research we've conducted or they are conducting. Well, this one is just the background, so but we're not going to do that. So apart from the primary research and the secondary research, irrespective of whether you are doing primary research or you are doing secondary research, now we are moving to the horizontal, or no, vertical axis, the vertical line. Irrespective of whether you're doing primary research or secondary research, the vertical line shows from the top your primary research. Now, this is not exclusive. There are other things beyond these two that I've mentioned. It includes quantitative research or qualitative research. So in both primary research, you can have both quantitative and qualitative research in primary research. And in secondary research, you can have both quantitative and qualitative. And of course, beyond these two, we can have mixed method, but we'll probably brush on it as we go along. So in my first quadrant, on my top left-hand side, whereby there is the intersection between the primary research and the quantitative research. So there is an example relating to falls, and you can think of an example in your setting. So a quantitative research can be a prospective study whereby so you are interested in measuring the frequency at which older adults failed, and you measure it going forward. Another quantitative primary research can be our famous RCTs. You can do your randomized control trial where you test your interventions among you want to see whether exercises, whether certain balance exercises work among those patients, and you do your randomized control trial and do that, but we're not going to that. It's another way you can do that. So these are examples. Our RCT is the typical randomized control trial or cohort study or longitudinal cohort study, whichever one, is an example of primary quantitative research. Still on the primary research, if you move across between the intersection between the quantitative and then the secondary research, it's an example that of secondary quantitative research. Now, an example of secondary quantitative research is you can decide to do a meta-analysis of false incidence rates, whereby you collate a lot of articles, a lot of research that has been done, and you bring them all together and you sit down and you sieve them. It gives you a relative risk, how much confidence interval, or how much you can depend on this data to apply in your clinic. So that's a secondary research on the meta-analysis of false incidence or false incidence rate. We can also have a systematic review of false incidence rate. In the secondary quantitative research, we can also have systematic review and meta-analysis as one study where you report the collection of different studies. Okay, so review, the secondary part is where we gathered different data to give us a picture. So rather than relying on one single primary RCT that was done, we can bring multiple of these RCTs, 10, 25 of them together, and it gives us a better picture of the evidence. Secondary research, it's quite interesting and important because a lot of research will be conducted by individuals. As clinicians, you are super busy to go through all those articles yourselves. And frankly, you probably just want to crack on and see your patient, apply the evidence. So secondary research, it's a nice way of getting evidence and applying it without you involving yourself in conducting the research. You can of course, secondary research, you can conduct the research, but the outcome of the secondary research, it's an important source of information, to guide your decision making information, whereby you have a collection of different ideas together, thereby minimizing the risks associated with one research, whereby it might be and there might be error in the study design, but you are seeing this a broader, bigger picture of the data. Coming down on the qualitative side, we also have primary qualitative research, the intersection between the primary and the qualitative. Now, examples are interviews exploring fears of falling, for example. We can't measure that quantitatively. You can, it's an abstract terminology. Fears of falling is an abstract terminology. Sometimes, yes, you can use outcome measures and everything, but for you to deeply understand people's point of view, people's experiences, quantitatively, it's not the appropriate way to do it. It's qualitatively, where people share their stories and experiences, and then you gather it. So the primary qualitative research, you can do that by having a semi-structured interview or focus groups where you sit down with people either one-on-one or in group of settings, and then you have a chat on their views, and then you sit down and analyze whatever data you want to do. But apart from also primary qualitative research, we have secondary qualitative research. In the secondary qualitative research, we have the systematic review of the qualitative studies. Okay. Here, you don't have meta-analysis, mainly is what we call meta-synthesis. Okay. Yes, you can have systematic review of the qualitative study. And if you go over between the intersection between the quantitative and secondary research, you can have systematic review of the quantitative studies. But in the intersection between the secondary research and the qualitative research, you don't have meta-analysis, you only have meta-analysis. And the reason is because the meta-analysis is a numerical arithmetic or calculation of the numbers. And that is the major defining difference between quantitative research and qualitative research. Quantitative research deals with the numbers, the numbers. Your SPSS is quantitative research. The numbers, they are more worried about testing intervention, testing theories. They are more interested about counting the beans, 1, 2, 3. That is all quantitative research. They are more interested in controlling the variables and seeing exactly what is the active ingredient. But in reality, we all know that is practically impossible. Well, most of us, all of us, that is practically impossible for you to answer all questions by using quantitative approach where you count the numbers. There are some abstract terminologies that you cannot be able to do that. And that's where the qualitative research comes in. The qualitative research, it's about exploration of people's experience, feelings, and attitude towards an intervention or something to give you a rich, in-depth concept of what you are about to do. And it's maybe important because it's a defining moment for intervention. You can have a beautiful piece of research, but it will make no sense to those recipients using it because there is no context to it. So if you look at it, you can say it in a way, in code, that quantitative research is objectively looking at the data, while qualitative research is subjectively looking at the data because it's all about words of the patient. But this subjectivity, it's important in developing the narrative, in developing theories. So when there is nothing to test, no theory, qualitative research is good to develop theories. Earlier in the morning, I asked you about the context of the experiences of your patient you've seen. What are those factors that influence them in socio-economic factors that affect their falls rate or affects their the fall for the rate at which they fall. Now you can count the number of which they fall, fine and good, but sometimes those cultural concepts, for them to be explored or to be understood in a research context, qualitative research is the best approach to explore those cultural, socio-economic factors that influence people's attitude, behaviors, or exposes people to risks of an activity or one or two things. So that's what. So quantitative, qualitative, they both complement each other. They have both their strength, and it's absolutely important we understand. It depends on the research approach what we're going to do. Which research approach is it? Quantitative? Are you trying to test for theories? Go for quantitative. Are you trying to explore, develop theories? Go for qualitative. Are you trying to objectively test for data? Go for quantitative. Are you going to trying to subjectively understand the context of people experience? Go for subjective, qualitative. Counting the beans? Go for quantitative. The quality of beans that you are counting, then go for qualitative. It gives you that rich context. So that is a background explanation of those four pictures that I have on the slides. And I think that's good. We are almost at the half mark. We're almost 50. That's good. That means you didn't just run away and leave me here talking. So we having said that, evidence-based practice, it's the norm, is the practice, is the expectation here in UK, and I believe also is the expectation in other places. As a clinician, you are expected to use evidence to support your clinical reasoning. Okay, and if I believe most of us are doing that, most of you, if you are not doing that, then I would like you probably today after the session to always have it in the back of your mind that are you using evidence-based in your practice? Are you using evidence-based in your practice? Because it makes a lot of difference to your patient. Are you using evidence-based in your practice? And what is this evidence-based? Is you as a clinician, is your ability as a clinician to use your clinical expertise to find the best researched evidence, okay? To find the best research evidence where you want to apply it, taking into account your patient preferences and values. So look for the highest research evidence, and by the highest research evidence, anything that is publishable out there. It can be primary research that we talked about. It can be secondary research. It can be systematic reviews, for example. It can be clinical guidelines. We talked about the NICE guidelines, but not every time you have the NICE guideline. So, but your decision as a clinician should be informed by what is the most current and reliable information. So there is need for you to be able to find those evidence. There is need for you to be able to find those evidence taken into account. So there are three key components that should embed your practice as a clinician. One, the best available research evidence in that area that you are looking at, whatever area you are in, whatever area you are in. Two, the patient preferences and values. Because you are doing it for the patient, there are lots of evidence that shows the effectiveness of a treatment can be influenced by by the adherence of patients to do those exercises. The reason why the patients are not doing exercises, coming to your clinic 30 minutes a day, 1 hour a day, will never be enough for a patient to get the most benefit of your rehabilitation. In most cases, apart from those quick fix, there are a lot of interventions that you can do. One tick box, one session, 2 sessions, but for a long-term benefit, a long-term empowerment for them to carry on, especially as physio, mostly we are doing exercise administration and things like that. For the patient to take ownership, for the patient to be active participants in the rehabilitation process, because patients are active participants in their own journey of rehabilitation, then you need to take into account their preferences and values. This can be in the context of looking at their home environment. What do they like? What is their goal? And tying your rehabilitations around their goal or their hobbies. It can be maybe there are value system. We have of different faiths here. It's important you on the patient dignity and values, whatever it is that they culturally you take that into account when you're applying that. It might be the best evidence, but sometimes it might contradict with patient values. If there is alternative, good, fine and good. And you at the center balance this both. And in the next couple of slides for the rest of the afternoon, what I will be doing is we will take a journey of how you, the clinician, can go through the process just to give us a nice introduction of how do you go about supporting your patient by using the best available evidence. Okay, so there are 5 OAs, if you can call it, how in terms of how you practice this evidence-based practice that we've been talking about. There are 5 A's. There are 5 A's. The first A is the asking the clinical question. We will take in turns to look at each and every one of them. The second is acquiring the best evidence. Okay, acquiring the best evidence. The third is you need to appraise the evidence. The fact that information has been published out there, that doesn't make it a norm or law. You need to appraise them for the quality of those evidence on their own, but also you need to appraise them in the context of which you will be applying that evidence in your own setting. Because a nice, beautifully evidence in somewhere done in Channel Islands, for example, might be different from the one that you will apply it in maybe in an area in Potaki or something like that in your settings. And then, so the application, apply the evidence in a practice, how you go about to apply it. And then at the end, you assess the outcome because you want to see whether it's working or not. And you reviewed it and you start the whole process again. Is there any question so far before we move on to the first A, which is the ask? If there is any question, you can drop it in the chat box. Let's have a quick look. Okay, yeah. Okay, yeah. Oh, so none. All right. So the first A is ask. Now, patients will come to our clinics with their problem. So the patient will come to our clinic with their problem. Sometimes they will ask us what is wrong with them, or sometimes they will tell us what is wrong with them, or sometimes they will tell us their symptoms or what is wrong with them, or the signs, or their concerns, basically. And yes, we may know what to do about it, or maybe we've been doing something about it, but it is not making a difference. I guess that's when we can reflect and think, is it the best treatment for this patient? Is it the best treatment for this patient? Because I've been doing this thing, but it's not. Is it the best treatment for this patient? Or because we are not omnipotent, is it, or we don't have all the answers, then it might be worth, they will tell us the problem as clearly as possible, but we don't know all the answers. So we may have to probably take it, and it's part of the professionalism, and go and find the information on what is the best treatment for this patient. So questions can come in a different format. Patient will ask you, or maybe it's you that will reflect on your practice, or patient relative will ask you. So it's not about research in sense research on its own. Of course, we can develop a question for research, but the questioning is about our patient asking us, this is the problem, what is the solution? But also, it can be a question that maybe you want to conduct a research and you want to frame a clinical question. So that's the first ask. The purpose of the ask is to help us define a clinical problem in a structured way. Because if we go and do Google search, sometimes we might miss some of those important information. So it ensures that our evidence research is targeted and efficient to avoid the vague, overly broad questions that may lead us to having multiple irrelevant results. So sometimes when you go, you will see no, you might have irrelevant result. But the question here, I guess, is how do we structure a good clinical questions? How do we structure a good clinical question? Our patient will not care about all those things. They will just ask us, oh, my leg is paining, oh, I have fallen, for example. I fall 2-3 days a week and I don't know what's wrong with me. Or maybe you've identified what is wrong, but you want to find the evidence. So how do we structure that? There are different frameworks that helps in structuring those clinical questions. I guess maybe some of you have come across it. There is the PICO framework, literally PICO framework, PICO, for structuring clinical questions. There is also the SPIDER, there is a SPICE. So there are lots of frameworks that has well-researched evidence for us to help structure this question. But the most popular, I guess, is the PICO. But we have the SPICE or the SPIDER as well. Just to ask and see if can you use the chat function for those that are if anybody that is familiar with the PICO and the SPIDER, can you please put the full meaning of that in the chat box? Or you can unmute yourself to share your idea. What is the full meaning of the PICO or the SPIDER? And what is it used for? Anybody? So structuring a clinical question, if there is none, that's fine, but just so that I know how much detail I can go in. So there are lots of them, but as example, we have Pico and we have Spider. So the question is, what's the full meaning of Pico and what's the full meaning of Spider? Okay, Suleiman is putting it, yeah. Okay, so PICO stands for, sometimes you can call it population or patient characteristics. I is the intervention at which you're looking at. C is the comparison or alternate of the intervention. And O is the outcome. Okay, thank you. And what's the full meaning? Maybe let's explore PICO a bit before we go to the other bit. And what type of research is, so you can use this for all of it, but PICO is mainly used for sort of quantitative type of research. Is nicely suited for quantitative type of research that we discussed earlier, but that doesn't mean you cannot use it for other sort of type of research. So yes, thank you, Suleiman. So yeah, that's the PICO framework. But we also have the spider. Anybody wants to give us the full meaning of spider before we move on? Okay, thank you. Not the spider web. Okay, sample of interest. Yep. Yep, design. Yeah, so the spider, while we're waiting for the rest of the spider, research type, okay. It's mainly suited for qualitative type of research where you are looking at the context of that research to structure it. And we'll be looking at a couple of examples. Okay, thank you, Suleiman. That's brilliant. That's a good effort. So we have PICO to structure a clinical question. We have research. And I'm going to talk about it starting with the PICO. So take, for example, you have a patient, Mrs. B, a 79-year-old woman with a history of falls. She's fallen twice in the last 6 months. It can be any patient that you see in your clinic day in, day out. You can substitute it with any patient. Now, this patient has mild balance impairment and lives independently. Certainly is a problem for somebody who lives independently and is falling two times uh, in the last 6 months. So the question is, taking our PICO, looking at this example, and I want you to either please unmute your mic or type it in the chat box. We said our P stands for patient characteristics of population of interest. What is our P in this case scenario? What is our P in this case scenario? What is our I if you're going to look at in this case scenario? And what is our C or not in this case scenario? And then what is the outcome? So the case scenario is on the PowerPoint. In Mrs. B, okay, can't see the slide. Oh, can I confirm that people can see the slide, please? If you can see the slide, can you let me know in the chat box or just yes, okay, brilliant. Okay, so I think it's just some of us. So I'm going to put the case scenario then. If not everybody can see the slide. So let me put it on the chat box. We can't see the slide. Why? But some people can see. I'm not sure. So sorry for those that can't see the slide. I'm not entirely sure why You cannot see it. So I've typed in the case scenario. So the case scenario, I will read it also for those that I guess some people can join via phone for the using the details. So Mrs. B is a 75-year-old woman with history of 2 falls in the past 6 months. She has mild balance impairment and lives independently. So my question is, and I really want you to help me, what is the P? So we say P stands for population or persons of interest. So this is your patient, comes to you, these are the problem. We want to start by asking a relevant clinical question to go and find the evidence. So the step is to structure the clinical question so that we can go and find the evidence in the internet. So let's put it that way. But for us to do that in a structured way, we will need to have to structure it. And one of the frameworks is PICO. So can you help me using this? What is our P? What is the population? Or maybe let me give an example and maybe so that we don't take much of our time. So the P in this case scenario is older adult with, yes, older adult with history of falls. So 75-year-old, yep, elderly woman. So the population OP can be older adult, which by definition, they are 75, the 75 falls that. Thank you so much, Halima. The word geriatric also can be our P because, so this is what we call synonyms. And I will come to that about senior citizen. Yes, Suleiman, you are way ahead of us. Yes. So yes, our population, taking it directly from the case scenario, it can be older adult with history of falls. But when you want to carry out a research, you can have variations by looking at synonyms or words similar to the population, and that is what Suleiman and Halima have put in. So whether you use older adult with history of falls, you use elderly woman, you use geriatric, you use senior citizen, they are all correct. When you put it in a database, these are words that the literature or the internet will identify. So that's one. The next one is the I, which is the intervention. Now, the patient presents with mild balance impairment. So what we need to do is to improve that patient balance. And we can do that by a lot of things, but let's take, for example, we need balance and strength training exercises. Okay, so we want to find out the evidence or what is the best balance and strength training exercises for elderly citizens. We are looking out for the evidence of balance and strength training exercises for elderly citizens. Okay, the evidence of balance and strength training exercises for elderly citizens. We can now compare it with the C is for comparator, and that can be compared with a usual care, or sometimes you don't have to compare it with anything, but you can compare with the general advice or working, nothing specific, just general interventions that is out there. And then the outcome is we want to reduce Mrs. B falls risks, and we want by improving her balance. So you can your outcome can be in number rates of falls basically. So this intervention, let's say balance training, this particular balance training, what is the percentage rate of fall? Maybe by 30% reduces the, once you administer this intervention, there will be almost 30% reduction in falls rate, or within the last next people completely eradicated, and of course improvement in balance. We talked about earlier on assessing balance. One of the outcome measures is time up and go test or back balance scale. So it could be that once you administer this balance training, If I remember our scores, we talked about out of 56, maybe Mrs. P, she is in the range of 30 out of 56 using the back balance scale. But once this intervention is administered, you want to see improvement in balance, maybe she will be 54 out of 56, something like that. There may be those interventions. So you're looking at outcome, improvement in balance. So your clinical question, of course, we will talk about the searching and everything, but if you using the PICO, it helps your mind clearly define what you are looking for. And if you are coming up with this question, an elderly woman walking into your clinic, oh, hi, doctor, I have fallen twice within the last 6 months. I'm worried. I live alone. I don't know what to do. Can you help me, please? Maybe that's all she will tell you. Hi, doctor, I've fallen within the last 6 months. I'm worried. I live alone. Can you help me, please? And then you look at she has mild balance impairment. So your question will be, in the older adult with history of falls, does a structured balance and strength training program reduce falls risks more effectively than usual care? So rather than just asking the patient to be just going and walking, or maybe just climbing her treadmill, does this improve structured one, whereby you structured it, targeted one, and then you go out and search for the information? So that's our ask. First example. Now, my question is, let's look at this is our ask, first example. What research approach can best answer this question? What research approach can best answer this question? The question is, in older adults with history of falls, does a structured balance and strength training program reduces their falls risks more effectively than usual care? What research approach best answered this question? Anybody wants to give a shot? So broadly, I'm asking between quantitative. Thank you so much, Abdul Hamid. So thank you, quantitative. But I usually always have one question ahead. Why quantitative? Why do you say quantitative? Either Abdul Hamid. So the answer, yes, is quantitative. But Suleiman say qualitative. Maybe not. Okay, that's interesting. So there is practically two different qualitative, quantitative. That's absolutely fine. Now let's look at it in detail. Why quantitative? Why qualitative? Abdulhamid, do you want to, or anybody who shared the views with Abdulhamid, why do you think it's quantitative? For those that I think qualitative, we'll ask you, why do you think it's qualitative? Peter, Abdulhamid, or anybody really here that feels like quantitative is the best approach to answer this question? Why? Yes, is it the person raising hand, Peter Abdulhamid? Yes, over to you.
Good afternoon once again. Thank you, sir, for sharing this vital knowledge. My view is that quantitative research actually deals with any measure that can be quantified.
Okay.
Like the number of falls within the last 6 months. So using quantitative variables, we can easily make a research clinical judgment on that. That's my point.
Yeah, thank you so much. Well noted. Let's move to qualitative. Those that say qualitative, why qualitative? No, Suleiman, you cannot retract your statement. You have to defend what you started with your full chest. But why do you retract it, Suleiman? Why do you retract your statement?
The number of quantitative is more appropriate than qualitative.
Okay. Okay. Quantitative is more appropriate. Qualitative is asking. Okay. Abdurrahman, you said qualitative. It is asking numerical value, looking for data for no fault. So Abdurrahman, you said qualitative. Can you expand on that? Okay, you mentioned it, but is it what you said? I think Abdurrahman, maybe not, because I think you're mixing when you talked about numerical value, you are talking about quantitative, and I think PT Abdul Hamid have succinctly articulate that point that quantitative numerical value, number of falls, can be counted in even in simple terms, and that is quantitative. Uh, uh, and qualitative, it's about the context of that experience. So looking at the question, I know Ezekiel mentioned it's mixed. Um, it can be, but you have to structure the patient. This looking at this, it's purely quantitative. It will only be mixed when you have a spin to it where you will measure, you have some interview, you have some experience that you will gather. But looking at this, I will say it is quantitative. And the reason is because what Abdurrahman has said. I think I cannot do a better job than what he did. So let's move to the next bit. I have another one. You guys should help me. I think we've done the first example. I want you to help me. So you're a patient by name Mrs. E. Just come into your clinic. In fact, maybe her family. She fast falling in the garden, and then her family brought her to your clinic. She has sort of a history of mild cognitive impairment, and they are worried for her well-being. What framework will you use, and can you outline the framework for me? So are we using, or maybe let's make it easier. We still using the PICO. So can you, from the question, can you outline the population or participant for me? Can you outline the intervention for me? Can you outline the comparator for me as well as the outcome? And you can speak, please. If you want to make a contribution, you can unmute yourself or you can type in the chat box. Anybody, please. So you can unmute yourself and or you can add in the chat box. Oh, I think some people say they can. Yes, I'll put on the question. I need to put in. Yeah, I forgot about that, Suleiman. Let's bring the question up. Where is our question? Yeah, so that's the question on the chat box. So let me know what you think. Okay, elderly population, Abdulhamid, yes. Elderly population, yes, that's good. But does it capture the characteristics of our population enough? When you say elderly population, geriatric patient with cognitive impairment, so that is a bit more specific. Either elderly population, yes. So elderly population or geriatric patient with cognitive impairment, that sounds a bit more specific. Yes. Is there anything else we want to add apart from elderly patient or geriatric patient with cognitive impairment? What of the intervention? Yeah, we will come to that. So we are just structuring the question. We will come to the assessment of the mental status of the patient using some outcome measures. But we come to that. We just want to structure the question, unpack the question in a way. So what is the intervention? So we have, although we can still add on the population. So we have two contributions for the population. What is the intervention? Possible intervention? And possible comparator, if we have any. And then what is the outcome we are looking at? So what is the intervention and what is the outcome we need looking at? So most effective intervention in management geriatric patient with cognitive impairment. Okay, so that's a question in this. So it's too broad. So we need to now thank you for the contributions, Leon, but I think we need to make it a bit more specific. Because if we say effective intervention, that's what we are here for. We need to find what is that effective intervention. Dr. Omar is telling us the cognitive CBT, okay, strengthening, okay. So are we looking at CBT plus strengthening versus not CBT? You can use that, yep. Suleiman is looking at aerobic exercise versus balanced board exercise. Yes. However, is that relevant to our patient? Remember, we said this patient has cognitive problems. So is there anything else we can add to those aerobic exercise? Because aerobic exercise will not address, although we cannot treat the mild cognitive bits, but is there anything we can do to help with that cognition as physios? So it's just a question, but thank you all for the contribution. So the P that we will be looking at is older adult with cognitive impairment, okay? And you can add it who has with false history. So it's not exhaustive. So the P can be older adult or senior citizens with cognitive impairment plus false history. Okay. Evidence suggests that aerobic exercise improves cognition at older adult. Okay. Yeah. Okay. That's good. However, there are, yeah, thank you, Suleiman. Maybe we'll look at what I mean. So the second bit is in terms of the intervention. Did you remember the activity that I gave you to do in the morning where I asked you to stand on one leg, then to count backwards and to close your eyes? So while the evidence, Lehman suggests aerobic exercises, but what is the most effective one? Because it might be that an exercise is better. I think the evidence shows that we have to have a cognitive loading because aerobic exercises is for cardiorespiratory function, is good, but we all know that cardiorespiratory function improves our general health and well-being. It increases the blood flow and everything. But for us to challenge that cognitive system, we need to have what we call cognitive loading. An example of cognitive loading is when I ask you to count in threes backward, you have to think. You have to do your mathematics and subtract three in threes, 100, 97, 98, and everything. So that's demanding. So that's an example of cognitive loading. And it helps with mild cognitive impairment in terms of to help them keep them alert. So yes, multitasking, I agree, but absolutely. So the intervention will be dual task training. The intervention will be dual task training plus. So when we say dual task training, you are doing more than one thing. At least two means dual. Multitasking is a lot, or maybe more than one. In this patient, we ask them to do motor activity because we know it can improve the balance. Let's say it's one of the motor component. It can be strengthening, it can be balance. And then we add cognitive loading. We add cognitive loading. And I've given the example of cognitive loading. We can compare it with motor training alone. So we all know exercise is good, but what of this patient is not just any other patient. This patient has a bit of mild cognitive impairment. What if we add a bit of cognitive loading, will that make a difference? What is the evidence? And then we go ahead and do that. The outcome we are looking at is reducing false risks, just as an example. But our intervention, it doesn't have to be cognitive dual taxing. Yes, agreed. Yes, I agreed, Suleiman. Absolutely. Our intervention, it doesn't have to only improve dual taxing. It doesn't have to be dual taxing. It can be, you can think of another intervention. There is nothing specific. It's not cast on stone. Home-based falls prevention program. So we can structure, we can say intervention can be, is there any, the patient doesn't have to be coming to the clinic. It can be home-based prevention program, combining strength and balance, and we compare it with usual care. Or no structured home-based. So we can decide to structure a home-based program for the patient, and then the patient can do that with no home-based. And the outcome, of course, reduction in falls risks, but it can be reduction in future falls, improvement, which can ultimately improvement in safety in outdoor activities, because the patient has fallen in garden. So we can look at outdoor mobility, dynamic balance, whereby they have to do other activities in the community. So, and that will be the same bit. So we can have our clinical questions structured around the PICO framework that we've developed. And like the previous one, the best research approach for this is quantitative research. And now clinical question, you just picking up from there, you can say, what is the effective strategy for improving, or is dual tax training more effective compared to motor training in reducing false risks among older adults with cognitive impairment? That could be something in that line with your question. Any question before we continue? And we can keep on having variations upon variations, variations upon variations of those clinical questions. And those questions, maybe just to mention, you can have questions of exercise intervention. It doesn't have to be exercise intervention. You can have questions of elderly individual. You can have questions of home safety. So you are looking at home safety. For example, the intervention will be home assessment and modification. You can have questions on balance training. You can have questions on nutritional supplement. A lot of questions. I will start with, I think there's somebody's hand is up. Esther, your hand is up. Yep. You want to say something, Esther?
Sorry if it feels like I'm taking you back, but I kind of joined it. The PICO acronym we're using, what is it for exactly? Is it to help in grouping patients?
Okay, thank you, Esther. The PICO acronym, I'm not sure when you joined. So when we started at 1:30, we talked about research broadly. So and then we moved to the evidence-based practice. So there are 5 A's in the process of evidence-based practice. So we have moved into research for clinical impact. So we're talking about research broadly. There are 5 A's. One of the first A is ask. As a clinician, you are expected to ask. So to ask the clinical question, to come up with a clinical question. So the PICO acronym it's a framework. So think of any framework, something that will help us to structure a clinical question so that when we went to the internet to search, it can be effective searching to find the right information. And we've given examples. So we're looking at it's applicable to all clinics. Your patient, for example, your patient will come to you and say, "Oh, I have fallen twice within the last 6 months. I live alone and I'm worried about my balance." And it's possible you don't know what is the evidence out there or you don't have the answers to that. How do you go about? Do you just go and type on the internet? If we go and type on the internet, it will give us a lot of information that might not be relevant. Sometimes it will be just a newspaper article, but which, as clinicians, we have to have the understanding of evidence-based practice on how to apply it on our patients. So the PICO framework will help you, in summary, to structure a question that either your patient have asked you that you don't have the answer, or you have reflected in your practice and you feel you want to update and find new information that will help you to change your practice. You use the FICO framework to structure the question. That is the first step of evidence-based practice. It's a process. So when you structure the question, we will talk about the next ones. You will need to go internet and search and find the answers, and then you apply it in your clinic. I know it's a long process, but I don't know if that's probably been cleared. If not, maybe you can have a quick look at the recording, or you can and do a bit of research around it. If it's new term today, I try as much as possible to keep it simple, but it might be too confusing, especially if you've come across it for the first time. I don't know, Esther, I don't know if that is more confusing or I have answered some of the questions.
No, I have actually answered it. You said P stands for people, I is intervention, O is outcome. But I
C
didn't
for
get what
comparison.
comparison. Thank you very much. Thank you.
Yeah. So you structured your questions to be able to find the answers in the internet. So that's the P. Irrespective whether you are in cardiorespiratory community. Now let me come back to the chart in the box. I think somebody asked, can we use Otago exercise as intervention? Absolutely yes. Absolutely yes. Otago exercise, you can use that as an intervention because there are lots of evidence out there, and you can find the evidence that shows Otago exercise is good. Absolutely yes, you can use Otago exercise. And I think let's continue. Let's see if there is any more chat in the chat bit. Oh yeah, so Suleiman has already answered. Yes. So, but I think the context that Suleiman mentioned, where for the person that have for Hassana, is that the Otago is meant mainly for home program. Now, this is where you as clinician need to think about the exercise you give to your patient. Now, Otago exercise is a good sheet of exercise, but for you to fully appreciate and understand it and to apply it to different patient population, it's good for you to go and find the evidence around Otago and everything and review it. And that's what we are doing it. First, when you review it, you will understand one, the setting at which to apply the evidence. Two, the type of patients that will benefit from the evidence, because the information there will tell you, oh, this exercise is good, but amongst which patient? This is a question you will be asking when you are reading the article. In which setting? Okay, at what stage of the disease will they benefit from? So all these questions will help you, and that. And thank you, Suleiman, for answering that. Let's move on then. I am back again to the Mrs. E. Now, somebody mentioned earlier about quantitative mixed method or quantitative. Now, we talked about quantitative, we talked about PICO. If we want to look at it in the qualitative aspects, we need to structure our question slightly different way. And spider, not actual spider, spider is a way of that will help us to structure that. And the spider, the S stands for the sample. The S stands for the sample. The EI of the spider stands for the phenomenon of interest. The D stands for design. The E stands for evaluation, what is being explored. And then the R stands for research type. So if we are looking at this case, Mr. E, who has mild cognitive impairment and falling in the garden, and we want to understand the patient experience, attitude, or perception to it, which is the purpose of the spider or the qualitative research, is we probably want to structure our question differently. When we are looking for information, we want to understand the sample of it as. So we are looking at S, the sample, which is sort of similar to the population. But the phenomenon of interest is we are looking at their experiences this time around. We are not administering any intervention. We are looking at their experiences and perception of outdoor safety after a fall. So it could be that after a fall, they decide to withdraw and not to engage. So we're looking at that. And the design, which is the D, stands for qualitative interview. The E stands for evaluation. So what are we evaluating? Is it their attitude towards outdoor safety, or how they feel about it, or coping strategies relating to outdoor safety? And then the R, the research type, qualitative. Okay, so the design D, it can be interviews, it can be semi-structured, you can change it to whatever, it can be focus group. It all depends on what you want to look at, the appropriate one bit. I'm putting it in the chat box because hopefully, so the spider. So the question can be, what are the experiences and coping strategies of older adults with mild cognitive impairment after recent fall? And the same can be also for the other case. The same thing, we can apply it for the other case, where we look at the same population for older adult. We look at the experiences of participating in group balance training. Maybe we want to administer group balance training, or we want to see whether it's going to be suitable for them. The interviews, and we are looking at what we are evaluating is perception of confidence and social support, and is qualitative. Now, as an exercise, and I will really appreciate if you do it, and then I want you to share your own answers on the chat box. I will give you 5 minutes. I'm still here. I will all be here. But I want you to come up to create a clinical question, irrespective of your setting. So think of where you are now. Come up with clinical question. Use either Spice or Spider, and then put it in the chat box. And if you are happy, after the 5 minutes, I will ask you to share your thoughts, or how do you arrive at this question. So put it in the chat box. I will give us 5 minutes, about 2:40. I will say by the next 5 minutes, I will expect to see some answers flying. Those that have their answers, they can put it in the chat box, but I will just give 5 minutes. I will stop talking for practically 5 minutes and see those answers coming on. If it's not clear, you can ask me and I will explain. So the idea is, let me put in the chat box, create Okay, still waiting. If you're done, just type in the response in the chat box. Okay, I'm still waiting. Come up with a question relevant to your settings and get ready to share. Okay, 3 more minutes. Nothing yet in the chat box. I'm still waiting. Okay. Thank you. That's economic burdens. Okay. Okay. Thank you for putting that. Can you create either the PICO or the SPI? Can you deconstruct your questions into that framework, please? Just let's see. So one is already there. Can we add information there? Whoever, Suleiman, can you deconstruct your questions as well? Thank you, Dr. Umar. Good, I can see it. Yeah. Okay. E is for evaluation, and R is for the research. So E is for evaluation and R is for the research. Let's see if I can reply. Yep, good. So E is for the evaluation and I is for the research, evaluation. So what you are looking out for, attitude or and then R is for the research. It's qualitative. One more minute. Come on, guys. Come on, come on. I want to see more. One more minute. Oops, it's already time. Anybody wants to share the questions they've come up with relevant to their clinic? Can you unmute yourself? I can see one on the chat box. Whilst he's trying to anybody wants to share? Thank you, Suleiman. I can see that you're trying to deconstruct your question. So the sample, the PI, phenomena of interest, are qualitative. So what design are you going to use? Economic burden. Somebody, is it? Hello, is the person trying to make contribution? Okay. Thank you. I think we'll make progress. Okay, impact on recovery. I think your question, you need to, I'm not sure if it's qualitative because it depends on economic burden, because you can measure the economic burden. You can look at it in the quantitative angle. If it's qualitative angle, Suleiman, you might need to restructure it very well. If you are looking at their perception or their experiences, then it's different. But if it's only the perception of economic burden, yes, that would be qualitative. So that's the first A, which is ask. The second A is acquire. So you will have that question that you've come up with. Then the next thing is you need to go and find the evidence. There are different evidence available. And how you go about to find the evidence is you find such databases. Now, there is nothing wrong, of course, in you just going to internet and search the information. But within the research, academic, and maybe evidence-based practice, it's encouraged. You can find there are what we call search databases. So these are databases that librarians have used, archived all peer-reviewed published articles. You can find them across those platforms. And using those search is easier. It brings them up. It's mainly for healthcare, and there are specific ones for healthcare. Example is Cochrane Library, PubMed, Pedro, and also you can use Google Scholar as well. They are mainly for peer review rather than just going to the internet and do a Google search and all the promoted article, Google blogs, and newspaper will coming up, which are not regarded as good sources of evidence for you and your patient. Is you find the databases, which are examples I've mentioned. And before you go in there, you can use the search terms. So the PICO or the spider that we structured, you use that in the search database, because sometimes those databases, they are more sensitive when you structure those questions like that, rather than taking the whole question or interventions for fall and put it down there. They are not very sensitive, not that nothing will come out, but structuring the question gives you an opportunity to get the best out of your search. And we can use the Boolean operators depending on the databases. You can modify those Boolean operators. But even not as a clinician, if you want to do a research as secondary research, if you want to find all the evidence, you can still follow those processes. And most systematic review or secondary research, these are the processes they followed, where you ask the question and then you go ahead to acquire that question. Now, what is important for us to look is the evidence you acquire, which will come to appraise anyway. So the purpose of the acquisition is make sure you gather relevant, reliable, high quality evidence that address your PICO question. The clinical decisions are based on the best available research. So the best available research and not on assumptions or some outdated practices, because evidence can change. Evidence can change. There are certain practices that are no longer in use because new evidence has come to light. For example, as famous as our infrared is, when I was practicing, I guess some other parts of the country no longer uses that. Not that heat doesn't have a place in rehab, but they find it an alternative way of doing things. So the evidence you will find, there are hierarchy to it, and the hierarchy, it's about how reliable the information. So yes, it is published, but that doesn't mean the information presented doesn't have flaws or errors. So the reliability of the information depends on where it sits in the hierarchy of the evidence. If you look at the picture on my right-hand side, hierarchy of the evidence, now it is recommended that we used published evidence that are on the very high hierarchy. One, because it reduces the risk of that the outcome of the intervention is not just due to random error. Some sort of biases have been minimized, and we can have confidence that if we applied it the right way, our patient will benefit from it. But not always do we always have that hierarchy of evidence. And in that case, we can use other alternate sources of those evidence, wherever they sit within the hierarchy, wherever they sit. At the topmost of the hierarchy, well, possibly, is the systematic review of a randomized control trial, because the systematic review, which is a secondary source of research from what we talked about, the systematic review, which is a secondary form of research, it's the collection of articles. But what articles did you collect? Is it primary? Is it randomized control trial? Is it cohort studies? So it's important we consider the systematic review of the randomized control trial seems to be regarded at the top. But right on, even above the systematic review, is our clinical guidelines. Clinical guidelines. So earlier on, I think we have a conversation around NICE guidelines. So NICE guidelines is an example of a guideline that is well regarded as a source of evidence for most practices, healthcare practices in the UK. And there are lots of countries having different NICE guidelines, and there are international organizations, different guidelines, and there are international organizations having different guidelines. But sometimes those guidelines is important. We look at what is the evidence they use to inform those guidelines. If those evidence is of a randomized control trial or systematic review of the randomized control trial, then it sits right at the top. But if it is not, then it might find its way somewhere in between those bits. And like I said, it's because of the likelihood of that we can trust the outcome of the study. And if we go all the way down, not every time we have evidence, sometimes expert opinion. So you as clinician are authority in your field. You've seen things that work. You've seen things that doesn't work. In the absence of evidence, an expert opinion is considered as a source of evidence where you can use your expert judgment to apply it for the benefit of your patient. So acquire simply is taking your clinical questions, the ASK, and going to a databases and go and find the information that will support your practice. So that is the acquire bit, using that bit. And what does it look like? Just as an example, what does it look like? It looks like this. Our earlier question is Mr. B, a 75-year-old woman with a history of falls, 2 falls actually in the last 6 months, mild cognitive impairment, and lives independently. So the PICO question is, in older adult with history of falls and mild impairment, does participation in balance training compared to usual care reduces the risk of fall, future falls, and improve balance? So for us to go and do our search, we need to come up with keywords. Earlier on, I think there are a couple of people, when we say our population, which is our P, we said older adult. Some people added senior citizens. Some people say geriatrics. All these are correct synonyms, keywords we can use. That doesn't mean we cannot use the older adult and its own. We can, but sometimes you can have some variations in the word so that it enables you to capture as many information as possible. If you are still looking at my slide, and I hope you are, for those that are not, I will try as explain as possible. If you look at it, after the older adult, under the search strategy, when I put keyword, is the word and the and is put in a capital letter. These are what we call Boolean operators. They help combining the words, narrowing your search, making it relevant. What it means is that it will search the database and find either the abstract, depending on how you filter it, or the title, where it has to have older adult and balance training. All in, it doesn't have to be the same sentence together, but it has to be somewhere within the article. For you even to start looking at it, it will bring you articles that have older adult. It will bring you articles that have balance training. And then you can add the falls prevention. So the older adult in this case will be the population. The balance training will be the intervention, and then the falls prevention. It can also be either the outcome. There can be the outcome, and it will search the database and brings you everything that has to do with this. And then from there you can start to walk your way through. And I mentioned about keywords. Another alternate way is, for example, looking at this older adult, when we have variations in the keywords, instead of older adult, we can have senior citizens, we can have elderly. So you will have older adult because they all mean the same thing. So you will have older adult. Before you reach to the and on my screen, you will have or, and you put it in capital letter. Older adults or senior citizens or geriatrics. Then you put your and, balance training, okay? And you can have variations of balance training, balance exercise, for example, and then you continue. What it will do is when you put the variations between in the population, older adult, senior citizens, or geriatrics, it finds in the article anywhere where one of these three or combination of them is mentioned. So it doesn't have to mention geriatrics because sometimes there are variation in the terms people use. Even if it has older adult, it will come up. It doesn't have to mention geriatrics or older adult. If it has senior citizens, it will come up. And you can apply filters within the search. The filters is just a nice way of narrowing your search because you are looking for the recent best evidence, either limiting it to RCTs or not. It depends on the database, either limiting it to the last 10 years or not. It also depends on the database. So database, like we said, we have PubMed, Cochrane, Medline, Sinal, Embase, a lot of them that we can use in. Hopefully I know it's a lot of information in the Friday afternoon. I will try as much as possible to be gentle, and after today, hopefully you have a nice weekend and you can forget everything I said till Monday. The next bit, I think probably I will have a quick demo maybe before we continue, just to give you an insight. But let me also mention another one before the quick demo. The same thing you can have for quantitative, you can have it for qualitative, and this is the example I'm sharing on my screen. The same thing you have quantitative, and you can have quantitative, and I'm sharing on my screen. Yes, Pedro is for physio. Absolutely, yes, it's a physio specific thing, platform or database. So if we are looking at qualitative approach, or we're looking at yes, if we are looking at qualitative approach, and this is how we structure it. Now, don't be disheartened when you structured your question and you do your search. It is possible for it to come up with too many words. Then in that case, you need to modify your search, or too little words, or even none. In that case, you need to modify your search to bring you the information. Any question at this stage? Yeah.
I have a question, sir.
Yes, yes.
Where does meta-analysis sit on the hierarchy? Because there is somewhere I saw meta-analysis above systematic review. So I wanted to know, where does meta-analysis is in the hierarchy? Because in the other listing I saw, they said clinical practice guidelines comes first, followed by meta-analysis, then systematic reviews, then RCTs, down below the ladder till you reach to expert opinion. So I would like to know.
Thank you, Sliman. That is a brilliant, excellent question. So where does it sit? So meta-analysis sits above systematic review. What you described is right. However, it's not just the picture of the hierarchy. It's what constitutes the hierarchy. What do I mean? So in simple terms, what you mentioned is the right description, where you have the clinical guidelines all the way at the top, followed by the meta-analysis, followed by the systematic review, followed by the RCTs, and followed by other studies. However, why I said, and that's why maybe I didn't include it, and you are right to ask the question. I want to see, and you picked it up rightly. However, the meta-analysis, the systematic review, the meta-analysis, and the clinical guidelines all are based on a primary research. What it means is, if those primary research by their nature are inherently faulty or biased, it will be carried on to the systematic review, or maybe not meta-analysis, because meta-analysis is mainly its RCTs, but it will be carried inherently to the RCTs, to the systematic review, or the clinical guidelines. Take for example, when a review is conducted, when let's say a primary studies is conducted, and the best evidence at that time is cohort studies or longitudinal cohort studies, and there are lots of them, and there is a systematic review of that cohort studies. But there is also a recent study that has been done of a double-blinded, multi-centered, randomized control trial. By nature, if you are looking at quantitative work, randomized control trial and more so double-blinded, multi-centered randomized control trial have ticked the boxes of the in question, in quote. The hierarchy is just for sake of simplicity, but it's more complex and there are things behind it. But it makes the double-blinded randomized control is so hopefully is devoid of bias, minimize the biases, that whatever inherent biases that are in the cohort longitudinal studies, even though your systematic review is there at the top hierarchy, it will carry it on to the systematic review there. Although you will acknowledge it and things like that, but it's you as a clinician, you need to make sure you figure it out in the acknowledgement. So when that double randomized RCT is available, in terms of quality, and when you put them side by side, it is possible for the double randomized multi-centered RCT, which is well powered, to have less flaws, or the certainty that you will rely on the evidence more on that compared to the systematic review of lower studies, case controls, or cohort studies. So that's why. But in simple term, the hierarchy is, as you mentioned, clinical guidelines at the top, meta-analysis followed, systematic review followed, RCTs followed, and then the rest also followed. I don't know if I answered your question or if you have other questions.
Yes. Yes, sir. Thank you very much, sir. I have a question, but not now. I will wait for you to finish first because I don't want to run faster than my shadow. There's a question I was asked during an interview. So, and I was eager. Whenever there's a research workshop, I want to ask the question.
Okay. Okay. All right. So, I think we will, maybe when we have, we can, okay, let me have this a bit of quick demo, and then I will try to ask the question before we finish up today. It's good to ask questions. I'm going to share my screen. Just to summarize, we have the first A, we asked the clinical question. The second A is the acquire that we're doing. So when you are acquiring, like I said, you need to go to database, and I just want to give us a quick demo of a database that we can use. So I'm going to share my screen. I'm going to, let's try again, Timothy. Maybe not. Oh. Can I confirm that you guys can see my screen? Can you see my screen? Okay. Sometimes there might be delay in the. Okay, brilliant. Sometimes there are delay in the internet if we switch from one presentation to the other. So hopefully it will come up. But since other people have confirmed, I will carry on. So we said there are different databases. Can somebody give us example of database, and let's have a quick play with it? Any database?
Yes, sir. We have Pedro, which is physio-based. We have PubMed. We have Medline. We have even Google Scholar. It's also a.
Okay, so let's look at Pedro. Sorry, Cochrane. Now, if we are looking at Cochrane, just to let you know, Cochrane only stores, it's called mainly Cochrane reviews. It only stores secondary research. So we shouldn't expect to find primary research in Cochrane. And we talked about primary research earlier on. So secondary research, literature, desktop-based reviews. So this is a platform of how it will look like. You will come with your question. We said older adult. All you need to do is if you come to the search, you will come older adult. You just put older adult. You can change it with anything really. You can keep on putting the things here. Where do you want the information? Do you want the information on the title or the abstract, or the title, abstract, and the keywords? Certainly, I will not encourage you to say you want the information on the whole article and there is no any provision, all text, for example, because if you cannot find those information in the title, abstracts, or the keywords, then it's not even worth your time to spend time, because it's just, you need to save time basically. Okay, you need to save time because you can keep on searching forever and ever. So looking at the title and abstract and keyword is good. We can look at older adult. The intervention, we can say balance training, or we can change it to dual taxing. Okay, let's leave balance exercises, and it gives you some nice suggestions. We can either use the suggestion or we change it. Let's look balance exercises. Comparison, we don't need to necessarily put that. We can put outcome false, or we can put comparison if we so wish, but let's keep that false. And we want them all in our say false risks. We want them in. So what we are doing now is we want anywhere in the abstract title for this information, and we want the database to combine older adult, balance exercise, and false. And then we come and then add already. And then we come and just run the search. Let me just take this away. And then you click on the run the search. And then we wait. Oops. Yep. So that's it. So we have 7 reviews that are also. So we can see different reviews that are looking at. So this is a population-based intervention of false or fall related, whatever. And we can go ahead and check the studies and read it. That's an easy example, basically easy way to go about it. Now, the same search, when I mentioned, we can use, apart from the and, we can use or. All you need to do is change it, but the or is for when you have a variations in word. For example, in the population, when we have older adult and we said, sorry, is somebody saying something? Okay, in the population, when we have older adult, we said we can have older adult, we say geriatrics. I think that's what some people mentioned about it earlier on. Geriatric, so we can put geriatric. So older adult or geriatric or senior citizen. Okay. We can put senior citizens. All these we put all because they are citizen. How do you spell citizen? Yeah, all these are, we put all because they are of all the same domain. But we can add more section. So this, they are one word. Then we put our balance on the other bits. That's the intervention. So the 3 are in, or we can put also all for the balance if we so wish. We can add more for the balance. We can say, what is other words for balance? We can say postural control, for example, so we put the or, so it will be all the three words combined. That's our population of interest. Then we have the and balance and citizens. Oops, so that's the five limit. So maybe which changes to maybe we leave our balance and then we're looking at false. And we can run our search. So you can see when we expanded our population with the variations, it increases the article. So it's not, so it is possible not all article reported older adults, older article reported senior citizens, geriatric, and you can see a lot of comprehensive geriatric assessment false virility. So the evidence is more bigger and everything, but that's a lot, and we can modify it with filters and trying to narrow it down. Either we filter it within the last 10 years and we can put the custom range here, or we can change the interventions or the type of studies, or we can modify it. So that's just a quick way of just a quick whiz through. Let's come back to our slides. Is there any question? Oh, the screen is not visible. Oh, so all the talk I've been doing, I've been talking in the air. The screen is not visible. Can I confirm that? Has anybody, when I was talking, anybody have seen my screen? Anybody have seen the screen when I was trying to show the example? No. Okay, let's try it again. Let's try it again. No. Okay, let's try it again. So let me try it again and see. Can you see my screen now?
Yes.
Okay, better. So what I said is, let me start all over. There are different databases. And how you do that is you only come and then you can type, we're taking example Cochrane. You just type Cochrane and then it takes you to the Cochrane library. This Cochrane is meant for, what is it called? It's for reviews, okay? And you can come to the advanced search, or it helps you, you can do the PICO search, okay? But I'll probably go with the advanced search. So in the advanced search, this one that I have on my screen is, we put older adult, geriatric, senior citizen. All these three, older adult, geriatric, senior citizens, they are all the same but different terms. So think of synonyms and antonyms in our English. So the synonyms of older adults is geriatric, the synonyms of this thing. So because we put all in the search system, it will find anywhere that it talks about either older adult or geriatric or senior citizens in the title and abstract and the keywords. And then the intervention is balance training. So we are combining the population with the intervention and the outcome. And then once you find it, we just run the search. And once you run the search, you can, it's taking time. And then this will be your article, and you can limit it to the custom range within the last 2 years or within whatever date you want to. I can decide to limit it by removing the variations of population and just leave it older adult, balance training, and still run my search. And then it gives me this article. So that's what I did earlier on. And you can go and find the article and we read it through in the end. I'm going to stop my screen. I hope you guys got me this time around, but if not, I'm very sorry because I know we are pressed for time. I will have to probably continue maybe next time. So that's the example. The next bit is appraise the evidence. So we have acquire, we have asked, you acquire. Now the evidence you need to go through and read through and find out, does it make sense? When you are appraising the evidence, you are looking at quality. And when we say quality, you're looking at the methodological quality, the biases of those studies. So you're looking at the article itself in terms of its methodological rigor. Does it randomize or not randomize? Does it blind or doesn't blind? All those things. But the second thing you are looking at is relevant to the patient condition. If you're looking at patient with falls, 75-year-old patient with fall is certainly also different from a stroke patient who stroke patient, or maybe somebody, a young person without a history of falls. Is it applicable to your own context? Before we go, I think the most popular bit is there are several appraisal tools that you can use to appraise individual articles. Okay, several appraisal tools, and that is a workshop on its own. But just to mention, there is the CAPS tool or CAPS program for appraisal of different types of studies. The appraisal of the study is specific to those study quality, to the type of study. If you are looking at quantitative study, it's different from qualitative study because the methodology is different. So when you are appraising it, you have to use the appropriate appraisal tool. If you are looking at quantitative study, there are different study designs. You have to use the appropriate appraisal tool for those study designs. I will type it in the chat box. These two major programs, the CAPS tool and JBI, they have Joan Brinks Institute. They have robust platform. You can read more about it. We will have a quick practice if we have time. I want us to get to a break in the next 8 minutes or so. So the CAPS tool and the JBI have robust appraisal tool. This is a tick box checklist that it helps you to appraise your studies. They don't make the decisions for you. That's the side. The good thing is it's a tick box. They have clear instruction that helps you. But the other bit is you are the clinician. You have to make some of them is to guide you in making those decisions. So you have to know exactly what you're doing, what you're looking for, and for it to make sense. Okay, so I've typed the link of both of them, irrespective of the article. But let's go back to our example. Mr. B is a 75-year-old woman with a history of falls in the past 6 months. She has had mild balance and lives independently. So in terms of study quality, what we will be looking at in the study quality is we will check the study designs. We will look at preferably RCTs, systematic reviews, and RCTs. Can I ask, please, why should we be looking at the study design and why should we prefer systematic review and RCTs? Anybody? So why should we look at systematic review and RCTs? Why should that be our interest when we are when we are finding evidence?
Because RCTs mainly assess for effectiveness, like comparison between different interventions to see which one is more effective. And systematic reviews are sometimes are reviews of a lot of RCTs to get the exact interpretation of those research.
Okay, yes, that's one. Good. Any more? Okay, there is a conversation because good. Yes, Suleiman, yeah, my HOD, that's absolutely correct because it provides strong evidence that are ordered. When you look at the hierarchy that we talked about earlier, systematic reviews and RCTs, they sit right at the top of the hierarchy of evidence. And because they sit at the top of the hierarchy of the evidence, they are more likely to provide us certainty that the outcome of the intervention or the outcome of the investigation, because sometimes it doesn't have to be intervention, can be relied on. And then we move ahead to look at the methodology. So the methodology, you're looking at the adequate sample size, which expectedly RCTs should have sample size calculation, making sure it's sufficiently powered to avoid all this type 1, type 2 error. When the study is sufficiently powered, it avoids false positive or false negative, and you can see the results. When you're doing the quantitative analysis and everything, because the mathematics, that's when you're doing the appraisal of a quantitative study. But in terms of qualitative, is a different ball game entirely, and randomly assigned. And the randomization helps minimize bias. And we're looking at bias both in terms of the how the outcome measures is administered, whether the person administering the outcome measures knows about the intervention and they can inflate the results, or the participants knows about the intervention and they can try to impress you, the outcome assessor. And we talked about different outcome measures that you can use. And you can use Pedro scale. No, now Pedro has, apart from the fact that Pedro is a database, it has a Pedro scale. The good thing about Pedro also sometimes is you will have a lot of articles that they have already reviewed and assessed, and they give you the scoring. You can find them there. However, Pedro scale only mainly, I think, is biased towards quantitative study. So you will find RCTs, systematic review, clinical guidelines. I think they only consider RCTs. It does it. So that's one part. The second thing to look at is the relevance to the patient condition. And that's where you also come in. So how relevant it is. So remember we talk about our PICO and SPICE. So the peak population, the population under investigation, does the population include your own? So in the case of this, what I will be looking at in the article is, does it include older adult with history of falls? So that I will make sure it matches with my own bit. Now, sometimes we can extrapolate. It doesn't have to be word for word, but that's your judgment to yourself. The settings. Is the intervention designed for community dwelling adult? This, my patient is community dwelling. It's not hospital based. So it might be different. The settings. The outcomes. What does it measure? My patient has problem with their balance, falls rate, or mobility. Does it actually measure balance, or is just talking about confidence, or is talking about mobility or muscle strength? Because it can tick all those things. If it doesn't measure balance and this thing, it might not be applicable to my situation. And then the next bit is the applicability of it. Earlier on, when we talked about outcome measures, somebody said that the problem with back balance scale is the time. So also with intervention. No matter how beautifully crafted it is, if you cannot apply it, if it's not practicable, then it will just sit on the shelf. So when you are reading the article and trying to find out information, or when you're reading the guidelines, let's go for guidelines. The guidelines will recommend a lot of things in different settings. Is a broad guidelines. It's up to you to decide what is going to be applicable in your local context or local clinic. Do you have the adequate resources to apply it? Do you have the equipment and the training to apply it? Because there is no point of you putting a lot of resources, thinking and research and everything, and that cannot be applied. Then the last bit, which we talked about, is the patient preference. Patient preference. I will pause here before we continue. I think it's been talking for a while. Let's have a 30-minute break. It's good to have a break at this point. Let's come back by 4 p.m., please. 4 p.m. Let's go for a break. Let's come back for 4 p.m., please. Okay. So screen break. Let's come back by 4 p.m. Thank you.